This is your musculoskeletal PANCE review. Today's topic is musculoskeletal oncology. So when it comes to MSK oncology, you must take advantage of the fact that on an exam, the answer cannot be ambiguous. In real life, it can be ambiguous, but in a test scenario, it can't be. So the test has to point you in the direction of a tumor or a lesion. And they'll do that by describing the pain as being, number one, atraumatic. So no injury, no trauma. And two, it is constant and worse at night. This is as opposed to, say, morning pain. It's a pain in the morning. It's generally the test telling you it's some sort of rheumatologic problem like ankylosing spondylitis or polymyalgia rheumatica. So, atraumatic pain, pain constantly, pain worse at night. We are now in the tumor portion of our exam. I think it's helpful to learn these tumors by age. There are certain tumors that kids get, and there are certain tumors that adults seem to get. And if it is a child, a skeletally immature patient with a painful bone lesion, it's going to be one of two things: osteosarcoma, or Ewing sarcoma. Ewing sarcoma. First thing you need to notice is sarcoma. The ending of the word is very important. Sarcoma is a malignant neoplasm, so it is dangerous and aggressive. And what are these neoplasms making? Well, in osteosarcoma, the lesion is making bone. And that is helpful because on an X-ray, if this is a bone, you will see some aggressive process of this bone making this aggressive bone matrix in this sort of sunburst or hair on end pattern. You still might get periosseous reactions in Codman's triangle, which is just kind of reactive formation of bone, but really it's this malignant bone formation that defines osteosarcoma. Now, what does Ewing sarcoma make? Well, there's no such thing as a Ewing. What it is making are these round blue cells. Round blue cells. Sometimes they make these little pseudo rosettes. But more importantly, it is not making bone. It is weakening and maybe destroying bone, so you might see these looks like little moth-eaten, weakened parts of the bone. And because the bone is weakened, the periosteum will react. And that periosteal reaction is what we call onion skinning. So onion skinning does not mean it's Ewing's. Onion skinning just means the bone is reacting to something. So you can get this onion skinning in several different types of pathologies, not only tumors. The other thing that stands out with Ewing's versus osteosarcoma is that Ewing's is actually a systemic disease. So you're more likely to get the systemic symptoms such as fevers, elevated sed rate, elevated white count, which you generally won't see on osteosarcoma. So on an exam, if they have fevers and chills and white counts and elevated labs, they're pointing you towards Ewing sarcoma. There are some genetics you do need to know for this exam. For osteosarcoma, you need to know the retinoblastoma gene and P53. P53 also will put you at risk for breast cancer. And for Ewing sarcoma, there is a translocation you need to know. 1122. One way to memorize this is that if you were old enough to be alive in the 90s, the New York Knicks had a center named Patrick Ewing who wore number 33. So if you can remember 11 plus 22 is 33, it'll help you remember that translocation. The treatment for both of these is surgery. Both will require surgery. Surgery. Both have a role of chemo to play. But interestingly, only one responds to radiation. And that is Ewing sarcoma. And that is one of the things that Dr. Ewing found interesting with this new bone tumor that he found, was that unlike osteosarcoma, it did respond to radiation. So let's now move on to adult tumors. So this will be a similar question stem. Some sort of adult with atraumatic bone pain, constant pain at night. And by far the most common bone lesion in an adult is metastases. And this also includes, and I'll list them separately, myeloma and lymphoma. Two other important painful bone lesions on the PANCE exam is chondrosarcoma and osteoid osteoma. Osteoid osteoma actually can occur in children, but on a test scenario, more likely they're going to put this in an adult. So metastases to a bone, again, it's going to be adult with atraumatic constant pain. The 5 most common lesions that metastasize to the bone, we remember with the mnemonic bacon, lettuce, tomato, with pickles and ketchup. BLT-PK, and that stands for breast, lung, thyroid, prostate, and kidney. So they'll give you that case scenario, someone with a history of one of these lesions, and your job is to find where this lesion is coming from. So our workup for this, the next step would be a CT, chest, abdomen, pelvis. CT, chest, abdomen, pelvis. The chest looking for lung. Abdomen, pelvis looking for kidney. And we look for thyroid and prostate with PSA and TSH and T3, T4, the thyroid labs. And while we're at it, we usually also order the myeloma labs, your SPEP and UPEP. So myeloma, once again, the painful bone lesion in an adult. If they want you to pick myeloma, they have to give you the CRAB mnemonic that you probably know by now. CRAB stands for high calcium, renal failure, anemia, and bone pain. For some reason, on this and other exams, they really like to focus on back pain. But by no means is back pain sort of the only place myeloma can appear. Because of the anemia, renal failure, a lot of times they will have a patient who has fatigue. And then the next step for this, the definitive diagnosis is, as we said before, SPEP, UPEP, or serum protein electrophoresis or urine protein electrophoresis, looking for the M spike or the monoclonal spike. Lymphoma, probably less tested, but if they do want you to pick lymphoma that's metastasized to the bone, they will have this clinical scenario, and on the physical exam, they will have to put some sort of lymphadenopathy, and maybe splenomegaly, plus or minus splenomegaly. Chondrosarc is again, a sarcoma. So this is a malignant lesion, so dangerous, aggressive. And what is this lesion making? What is the sarcoma producing? It is producing chondro or chondroid, otherwise known as cartilage. So this is a cartilage-forming tumor, which means on an X-ray you will see changes. And on an X-ray, classically a cartilage-forming tumor looks like little rings and arcs. So as opposed to the sunburst pattern of osteosarcoma, a chondrosarcoma will be forming more of these little rings and arcs. The treatment for this chondrosarcoma is surgery, some sort of surgical excision. There is a role for chemo in this pathology, but in general, surgery is going to be your treatment for this. Osteoid osteoma, I'm putting this in the adult section, but again, this can occur in children too. This is, again, a painful bone lesion, atraumatic. And the key finding on this is that it gets much better with NSAIDs. And the reason why this is that, first of all, what is it? It is a little hole in a bone. A small hole in a bone, we call it a nidus. And what is coming out of that nidus? Well, what's coming out of that nidus are prostaglandins. So what's coming out of here is some prostaglandins. And as you know, with prostaglandins, do respond very well to NSAIDs. So because it is such a small lesion, this actually is a lesion that actually is useful to get a CT scan or an MRI, because a 3D imaging can show this little nidus. And the treatment for this, again, this is an osteoma, so it is not a sarcoma, it is not aggressive, it is not malignant, so you can treat it conservatively with NSAIDs and observation, serial x-rays. The test scenario would be about every 6 months. But if that does not work, you can use radio frequency ablation to get rid of the lesion. But sometimes that's not an option if it's, say, near a spine or some other dangerous structure, in which case surgery sometimes is an option. Now, there's one more lesion that you should know for this exam. I'm going to put it in its own little separate box. And that is osteochondroma. Osteochondroma. What makes this unique is that it is painless in general. So it is a painless lesion, usually found a bump on someone's limb or an incidental finding on an x-ray. So what is it? It is a chondroma, so it's not malignant. It's making bone, osteo, and it's making cartilage, chondro. And what you will see on an x-ray, so some sort of x-ray, no matter what the limb, you will actually have a little finger of bone. Very well defined little stalk of bone. And at the end of it, if you cut it open and looked at it under a microscope, is a little cartilage cap. So that's the chondroma of the osteochondroma. And since this is benign, the treatment is nothing or observation. I say benign on this level of test. These can become malignant in certain scenarios, but for the PANCE exam, treat this as a completely benign lesion. Now, once in a while, these do push on a nerve or a tendon, or they can become bothersome, in which case, second line, so definitely first line is observation, and as a second line, you can remove these bumps. So that, in a nutshell, is musculoskeletal oncology. My name is Will Kang. I'm a practicing orthopedic surgeon here to help you pass that PANCE exam. Follow me for more videos.